Dear audience, let me introduce to you my PhD thesis investigating the cardiac complications of acute pancreatitis. My name is Veronika Lillik. I'm a second-year internal medicine resident at the Hospital of Székesfehérvár, and my vision is to decrease the mortality of acute pancreatitis by foregoing the preventable complications. And my mission is to conduct high-quality research to understand the effect of acute pancreatitis on the cardiac status. I have 4 ongoing projects. The first one is via the methodology of systematic review and meta-analysis. The second and the third ones are protocol development for a prospective follow-up observational study. And the fourth one is a registry analysis regarding cardiovascular abnormalities before and during acute pancreatitis. Let's start with the first one. As you know, acute pancreatitis is a systemic inflammatory disorder with rising incidence and high mortality in the severe form. Organ failure is one of the most important predictors of mortality and severity, and heart is a common organ involved in the cause of death. The post-discharge management and mortality in acute pancreatitis is under-investigated. A recent registry analysis showed that in the first 90-day period after discharge, the mortality is almost as high as during hospital stay, and 22.5% of that post-discharge mortality is because of cardiac failure. But there is no guideline regarding this topic. That's why there's the need to cover the importance of cardiac-related abnormalities in acute pancreatitis. In recent cohort studies, it has been shown that the severe form of acute pancreatitis is associated with certain ECG, cardiac laboratory marker, and echocardiographic changes, cardiovascular failure, and myocardial dysfunction. The severity of acute pancreatitis is based on the revised Atlanta classification, based on the presence and the duration of organ failure and local complications. Our aim is to investigate the bidirectional association between cardiac changes and the acute pancreatitis course. Our clinical question was what cardiac-related abnormalities are associated with worse outcomes in acute pancreatitis. The population was patients with acute pancreatitis. The factor was cardiac-related abnormalities, and the outcomes were mortality, severity, and length of stay. The second version of our framework, the factor was the severity of acute pancreatitis, and the outcomes were the cardiac abnormalities. We conducted a systematic search with the following search key in 3 main databases. Our systematic search yielded around 20,000 hits, and in the end we could include 46 studies, and 26 of them could be analyzed in a meta-analysis. I will show the results based on the frameworks and based in a certain time frame. This is the first framework where the factor is the cardiac-related abnormalities. We could analyze pre-existing chronic heart failure as a past medical condition, concurrent atrial fibrillation, and in-hospital cardiovascular failure. The outcome was mortality. This is our first figure. We included 7 observational studies with more than 1.7 million acute pancreatitis patients. The heterogeneity is high in this case because it contained all the severity categories. The exposure is pre-existing chronic heart failure. The comparison is patients without this chronic heart failure, and the odds for mortality in patients with pre-existing chronic heart failure is 3.43 in patients with acute pancreatitis. This is a clinically relevant number and also statistically significant. In our next forest plot, we could include 6 observational studies with high heterogeneity. The exposure was the presence of atrial fibrillation. The outcome is here also mortality. And we can see that patients with concurrent atrial fibrillation have 2.69 times higher odds for in-hospital mortality in acute pancreatitis. This is our second version of the framework, where we analyzed the factor of severity with the outcomes of certain in-hospital changes in cardiac abnormalities, like on ECG, repolarization, QTc prolongation, regarding laboratory parameters, NT-proBNP, and some hemodynamic parameters like tachycardia, heart rate, systolic and diastolic blood pressure, and cardiovascular failure. This forest plot contains the 3 observational studies with low heterogeneity. Here the exposure was severe and moderately severe acute pancreatitis. The control was mild acute pancreatitis. We can say that patients with severe and moderately severe acute pancreatitis have 2.75 times higher odds for in-hospital repolarization changes on ECG. The strength of our study is that this is the first comprehensive analysis and the associations between cardiac abnormalities and acute pancreatitis outcomes. We could include studies with high patient numbers, but the limitation is coming from the retrospective nature of these studies because the time frames and the definitions are not well defined among the studies. The main conclusion of our study is that acute pancreatitis patients with pre-existing chronic heart failure have more than 3 times higher odds for in-hospital mortality. Acute pancreatitis patients with concurrent atrial fibrillation face 3-fold increased odds for mortality, and severe and moderately severe acute pancreatitis patients are 3 times more likely to develop changes in repolarization on ECG. The implication for practice is that cardiology screening in patients with acute pancreatitis is needed based on our meta-analysis, at least an ECG monitoring. And the second implication is that those patients who have pre-existing cardiac comorbidities should go through cardiac evaluation at baseline when they got diagnosed with acute pancreatitis. The implication for research is that more longitudinal follow-up studies are needed and more kinds of cardiac parameters need to be investigated. This is the progress of our first project. We are done with the first version of the manuscript and we are planning to send it to internal review this week. And as I mentioned in the implication for research, we are now conducting a prospective follow-up observational multicentric study to understand the cardiac functions during and after acute pancreatitis. As I mentioned in the beginning, and our meta-analysis showed that there are some changes that are associated with the severe form, but we can't make enough conclusions based on that. That's why we need to investigate this topic more and to find the bidirectional associations between the cardiac changes and the acute pancreatitis outcomes, not just during but after discharge also. We would like to conduct a prospective observational follow-up multicentric clinical study for the following questions. What are the incidences of these cardiac-related changes? What is the time dependency? And which on-hospital cardiac-related changes are associated with the severity and mortality of acute pancreatitis? And in the follow-up study, what are the changes after discharge and which in-hospital cardiac-related changes are associated with worse post-discharge outcomes so that we can predict which patients should be followed up more. We are now drafted the protocol. This is the progress of the second and third study. Our fourth project is done by the methodology of registry analysis. We are interested in cardiovascular abnormalities before and during acute pancreatitis with the same population. We would like to investigate the factors of pre-existing cardiovascular diseases, newly developed changes, ECG and echocardiographic abnormalities with the outcomes of mortality, the cause of mortality, severity, length of hospitalization, and the US alterations. We have our hypotheses that pre-existing cardiovascular diseases like chronic heart failure, hypertonia, atrial fibrillation worsens the outcomes of AP. And the second kind of hypothesis is that newly developed cardiovascular alterations on ECG, echocardiography, stroke, and thromboembolism is associated with higher mortality and severity in this disease. And we also hypothesize that the risk of acute vascular events is higher in this population. This is the beginning of this study. We have already made the data retrieval pen, but we will need to get access to the discharge paper of these patients. Here you can see the summary of my ongoing projects with the planned submission dates, and I would like to wrap up my presentation with a quote from Albert Einstein: "Life is like riding a bicycle. To keep your balance, you must keep moving." Thank you for your attention.
Much for your excellent presentation. I think the topic is very significant. Is there any question from the floor? Please.
You mentioned that. So my question is, what do you think? What is the cause of the ECG changes, namely the changes in the repolarization after or during acute pancreatitis? For example, do you have data about the electrolyte levels changes during acute pancreatitis?
Unfortunately, I don't have the data of the studies regarding electrolyte changes, but I know that from the literature that the level of potassium and magnesium and calcium are influencing the ECG changes or repolarization, but these articles are not the best quality. That's why we are planning to conduct a better study in this topic, because we think that there is an association between the electrolyte levels, ECG changes, and also the coronary function, because the repolarization is also based on the myocardial function, which can be caused by the myocardial depressant factor, which is a theory behind acute pancreatitis and cardiovascular changes.
About the quality, actually, you were the first presenter who showed the risk of bias, and congratulations for that, because it's important.
Congratulations for the presentation. Is there any measure to prevent or to treat this cardiac complication during acute pancreatitis?
I think the first step is to diagnose it and then prevent it, because now we don't know why these patients are dying, and this is really important to have a reason. And if we have a reason, then maybe we can prevent the mortality. Maybe more ECG. So acute pancreatitis patient follow-up is not the best around the world, and maybe cardiovascular evaluation should be included, for example, a simple ECG examination during these follow-up visits.